Just start in next 1 minute. Um, the participants are in now. All right, a very warm welcome to one and all for attending this session today. I'm Dr. Janardana Panatapura, JP. I'm one of the radiologists at Wake Forest. A very brief introduction about the Global Academic Radiology Education Program, the AREP, which is a nonprofit initiative aimed at providing high-quality radiology education to colleagues worldwide. So this was established in October 2021 and is based at the Department of Radiology at Wake Forest University School of Medicine. So we offer free online education resources and live webinars featuring academic radiologists from leading US institutions. The program is designed to bridge educational gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. So we host bi-monthly webinars which run from January to October, which covers various radiology subspecialty. We have the subspecialty sessions, which are well attended and up to 700 participants per live event, and include contributions from the esteemed institutes. And our reach extends to radiologists in different countries in Asia, Africa, and Middle East. So the program's success is driven by dedication to its committees, moderators, speakers who work tirelessly without external funding. In addition to webinars, we also offer projects like the Radiology Excellency Program, which focused on mentoring and specializing radiology challenges in various countries. So today, again, welcome for another great session on musculoskeletal radiology, imaging of spinal traumas. And our moderator for today's session is Professor Dr. Rosie Setiavati. So she's a professor in musculoskeletal and clinical radiology from University of Erlangga from Indonesia. So welcome, Dr. Setiavati, and all back to you right now.
Okay, thank you, Dr. GP. Good evening, ladies and gentlemen, all radiologists, radiology trainees in Asian, African, Middle East region, wherever you are. Welcome to the Academic Radiology Education Program on Sunday, 4 August 2024. We are very glad to present online webinar with topic of imaging of thoracolumbar spinal injury. My name is Rosie Setiawati. I come from Faculty of Medicine, Universitas Airlangga, Surabaya, Indonesia, and will be serving as your moderator today. You'll be hearing the presentation from Dr. Robert Lopez, MD. And before we see and hear his presentations, let me introduce the distinguished guest speaker for tonight. Dr. Robert Raymond Lopez, MD. He is a clinical professor on Department of Radiology, Wake Forest University School of Medicine, North Carolina, US. And he's joining for the RSNA, ASAR, ARS, and ESR, ISS, and ICD societies. And his subspecialty is musculoskeletal radiology, and he has about 30-year experience in radiology field. And maybe before the presentation begins, let me tell you about the webinar we'll run. Firstly, the speaker will present the material about 40 to 45 minutes. Following that, we will have questions and answer sessions, approximately about 15 minutes, and then closings. Now, we're moving along our sessions. Please welcome Dr. Robert Lopez, who will speaking to us on imaging of thoracolumbar spinal injuries. Dr. Lopez, now time is yours. Please.
Thank you very much for the very kind introduction. I'm going to try to share my screen, which hopefully we can do here. And hopefully we can get this presentation.
Yes, we can see the presentations.
Okay.
So good.
Do you see the slide now? We're good?
Sure.
Okay,
Thank you.
great. So I decided to basically focus on thoracolumbar injury. The imaging of spinal trauma is a huge topic. I wasn't sure I could give it justice in 40 minutes. I don't even know if I can give justice to thoracolumbar injury in 40 minutes, but I think one of the things we're going to talk about is sort of how important this topic is, as well as, what to look for as radiologists to help our colleagues in managing these injuries. And I have no financial disclosures relevant to this material. The cases and material, a lot of it come from prior educational exhibits by other educators, as well as prior literature, and I have cited as such. And I have a list of references in the last slide, which hopefully people can peruse and kind of look more in depth. Special thanks to one of my retired colleagues, Dr. Brian Howard, who is a spine radiologist and had a lot of this material on his teaching files, as well as I was able to get some more recent material as well. And of course, special thanks to JP, basically for the opportunity to learn about AREP and the wonderful mission, as well as the invitation to give a talk. So thoracolumbar spinal injury, it's actually fairly common because, as you can imagine, 50% of all fractures are going to happen in the thoracic and lumbar spine because it's such a large anatomical area. The cervical spine is going to have the rest of the 50%, and we won't talk about that today, unfortunately. So one of the things to remember when looking at spinal imaging is that there's a pretty high incidence, not trivial, of non-contiguous fractures. So it's really important to have a search pattern to really look thoroughly at the entire anatomy and not have satisfaction of search when one finds a fracture, which, as you know, can lead to bias to immediately start reporting that and then missing what could be a subtle but maybe more important clinical fracture. So at level 1 trauma centers, like the one I practice in Charlotte, the incidence of fractures in all patients and blunt trauma patients is about 5%. But a lot of these in my practice come from motor vehicle collision. We have a fair amount that come from fall from height as well, basically workers as well as people who are having fun, I guess, deer hunting and falling off tree stands, seems like, in North Carolina. And there's a big incidence of other major organs injuries as well. So a lot of these are kind of coming in on trauma packs. The delay in diagnosis of this injury is actually not uncommon because they can be kind of subtle. And when it does happen, there is actually a very high incidence of increase in neurological deficits, especially if there's early mobilization and a fracture is not recognized. So I think it's really critical to make sure that you look very thoroughly for these injuries. And one of the ways to sort of kind of do that is to familiarize yourself with the different morphologies and presentations, which hopefully we can talk about today. So looking at the anatomy, I think this is a nice example from radiology assistant of the thoracic and lumbar anatomy. And basically you can divide it into 3 main levels, T1, T8, some people say T10, some people say T9 to L2 as the thoracolumbar region, and then L3 to the sacrum. There are different kind of anatomical structures that are going to contribute to the biomechanics of this area. T10 L2 is a transitional area from a more rigid construct, which is the thoracic spine because of the attached bilateral ribs. And there is a slight usual kyphosis to the more flexible but lordotic caudal lumbar spine. And because it is a transition area, it basically has increased propensity for biomechanical stresses. and therefore is one of the more common affected areas for trauma. I mean, we can see trauma in all these areas. And excuse me, usually in the thoracic spine, a flexion injury pattern predominates. And in the lumbar spine, a axial load predominates. But we will see traditionally, not only in patients with osteoporosis, where we see common compression fractures, but in high energy traumas, we will see very frequent fractures in the thoracolumbar junction. So one of the ways to think about the pathophysiology of fractures in the thoracolumbar spine is to think about what range of motion we usually have in the thoracolumbar spine. And there are different shear forces that can act. And when we sort of kind of, quote unquote, overdo these in the setting of trauma, we can lead to pathological strain. So in this example, you can see multiple kind of areas of how the spine can be overloaded. One can have axial overload in A, or kind of a lateral bending stress, flexion and extension in C, which is a common mechanism, rotational mechanism, which sometimes can be overlooked in D, distraction, which is uncommon but can happen, and then a true horizontal shear injury. So all of these, when they happen outside the normal range of motion in the setting of applied force, can lead to thoracolumbar injury. And one of the things that is really difficult but essential is to try to figure out, after you've recognized these fractures, which of these fractures can be treated conservatively and which of these fractures can be treated with operative fixation. Now, you would think that this would be something straightforward, but it's not. You can actually talk to many spine surgeons and get many different answers. There are some basic tenets, which we will talk about, but it just means that, you have to kind of think about the overall patient, of sort of where the level of the fracture is, as well as the neurological injury. A lot of clinical data that we as radiologists may not be purview to initially when we are doing our assessment. One of the topics that is actually quite controversial is stability. And a lot of what we'll talk about is classification systems. And a lot of the classification systems have to do with identifying what is stability. And we don't really know in some classification systems what they use. The older classification, the more recent ones, they're a little bit more straightforward, but in the literature, it's kind of tough to tease these out on the older ones. When we define stability biomechanically, it means to maintain the alignment of the spine under physiological loads without a significant onset of pain or a progressive or intolerable deformity. And I think a lot of us think of stability that way, but there's also the more important stability, which is actually neurological stability, right? Which is basically preventing the onset of or worsening of neurological symptoms, which is really what you want to prevent in the patient. And the neurological stability, a lot of is many times kind of predated by the mechanical stability. So we will kind of focus on that. So stability, what's important to realize is, as radiologists, we're kind of looking at static stability, but really, what is happening is people are basically standing upright or walking. They are putting their spine under physiological loads. And when you have dynamic instability, you basically get deformities that worsen under normal physiological loads. So you may have a normal alignment when you're supine, when you're taking that radiograph or that CT, but when you stand the patient up and take a radiograph, there can be malalignment. And that's the true definition of an unstable process in the spine. You can also see this, if you look serially at multiple radiographs and see progressive kyphosis over time, then that tells you that there has been a dynamic component to this. And a lot of times when you are looking on the view box, you'll see many times pictures like this, where This is from the literature, but basically this was a fracture on CT where there is actually vacuum gas that has accumulated on this fracture in the L1 region, because when you are lying supine, you're actually extending in the CT scanner, which is, as you know, is not the most comfortable place in the world to lie down. And that fracture is actually enlarging momentarily, quote unquote, and creating this vacuum gas phenomena, which we can see in the setting of a fracture cleft. And when that patient is basically put on a brace, which is why there's all these little dots here, you can see the extent of kyphotic angulation that happens between on the upright radiographs versus looking at the supine. So one of the reasons that when conservative treatment is opted for by the clinicians, they will traditionally do an upright radiograph, and you'll see these, and you'll want to compare to the prior supines just to see if there's any marked change in kyphosis or if there's any horizontal translation, which would imply that it's potentially unstable and probably needs surgical treatment. We're going to talk mostly about what we can see in the radiographs that we can infer basically may be secondary to possible underlying instability. And this is important in the radiographs. When we look at the spinous processes, we want to make sure that the spinous processes are not focally widened, that the interspinous space is not focally widened, as well as any kind of biplanar deformity in AP and lateral view. Traditionally, it has been taught, if you look at the textbooks, that greater than 50% height loss and a compression injury or focal kyphosis of 30 degrees may predispose to potential intervertebral instability. But when you look at the literature, the data to support this is not really that robust, and it's more anecdotal. That said, a lot of surgeons still sort of kind of use this as when they're looking at radiographs. In CT, it's a little bit better because we can look more in detail at different structures, including the facets. The facets are incredibly important in helping with rotational stability. And facet complex disruption is a clue that there has been a very high energy trauma usually, and that there may be a potential for instability. And of course, the white interspinous distance, which we can actually measure a little bit better usually on the CT than we can on radiographs. And then, of course, there's MRI, and MRI, with its great soft tissue contrast, can directly visualize the disrupted posterior ligamentous complex, which is kind of the key towards stability from our perspective. And we will basically touch that a little bit later. So this is an example here from our practice. This 8-year-old was run over accidentally, struck by a car. And you can see that this is a compression injury of the L2 vertebra. This injury is called a burst fracture because there's involvement of the posterior wall. And when we do the MRI, one of the things that always strikes me is just how on this STIR imaging you can actually see edema on multiple of these vertebrae, which is really impossible to see on the lumbar spine. So the MRI really gives us a lot more better picture of the different stresses that have happened. Of course, the real reason we do the MRI is not to see these little non-compressed, minimally compressed areas, but to look at the extent of the compromise of the central canal, as well as to look for any ligamentous injury, which this patient fortunately did not have. And this burst fracture with minimal involvement of the canal was actually treated conservatively. And this is an example of the same child. This is the supine view. And now you can see, when you see these sort of telltale signs, this is sort of that external clamshell brace, so-called TLSO brace, that is traditionally used. And the alignment here looks about the same as the supine. The degree of vertebral body height is about the same, and there's no significant focal kyphosis. And here's the AP view. Notice a very slight widening of the interpedicular distance. So although this was a burst fracture, which many people sometimes think can be unstable, it does not necessarily have to be. And we'll talk about that. And that's one of the main points of basically this talk. So trying to figure out sort of how to communicate these findings between our surgical colleagues as well as other clinicians, rehab, and so forth. And also trying to figure out how do we basically do a better job of trying to assess stability. There have been multiple thoracolumbar spine injury classifications in the literature. This is a very short, believe me, history of them. The earliest one I could find is from Dr. Bowler. If you are a musculoskeletal enthusiast like I am, you recognize the name from the Bowler's angle from the calcaneus. And he also classified fractures by geometry and mechanism of injury throughout the spine. And he came up with different basic mechanisms. So an axial load, compression, a flexion with distraction of the posterior elements, an extension injury, a shear fracture, which we now basically more call fracture dislocation, and then rotational injuries. And a lot of these concepts are still valid now, although we don't really use his classification system, or most folks don't. Dr. Watson Jones is recognized in 1943 for recognizing the importance of the posterior ligamentous complex, which we will talk about as one of the keys for stability. It's interesting that this was a topic of much debate until very recently, but it was first proposed in the 40s. And he talked about what we now use the term of compression fracture as a simple wedge fracture. He divided it. He also talked about comminuted fractures, fracture dislocation, hyperextension injuries. Holtzworth is basically one of the people who described the spine in two major biomechanical columns, which will lead us to the next researcher. But he basically described the spine into an anterior column and a posterior column, with the anterior column being the vertebral body and the posterior column, everything posterior to the posterior longitudinal ligament. And again, he also classified it mechanically with mechanism of injury. And you can see that these themes sort of kind of come back and forth: compression, dislocations, rotations, extensions, burst. He used the term burst, which kind of caught on, in shear injury. I want to basically focus on these three researchers because Dr. Denis, in his paper in 1983 in Spine, basically was very influential in his classification, became very well known. In fact, when I was in my residency and fellowship, this was the main classification system that was talked about by the orthopedic surgeons as well as the radiologists. And to this day, many talks will reference this classification. It's a great classification system in the sense that it's very easy to understand, and we'll go over it. He talked about he took Holtzworth's 2-column and basically made it a 3-column. And he talked about this middle column, and the involvement of the middle column is truly what makes a potential instability, which is actually quite controversial now. Again, he looked at the different categories and basically came up with compression and burst, as well as flexion, extraction, and dislocation. We'll talk a little bit about the AO classification. If you're a musculoskeletal radiologist or orthopedic, the AO is a very influential worldwide as to fracture classifications. Dr. Madrigal initially did the classification when he published in 1994. This was an extremely comprehensive classification. And one of the nice things about it was the first time that anybody tried to kind of look at these classification systems progressively and sort of kind of do a hierarchy of damage and, what can correlate with stability and severity, which the other classification systems didn't really have. Because it was so comprehensive initially, the initial AO classification had 57 subtypes, which sort of goes along with a lot of the AO other classifications for other bones. Unfortunately, they're very comprehensive, but very difficult to use in a day-to-day clinical practice. This had very low intra-observer reliability and actually did not have a lot of folks that were kind of using it. But since 2013, there was a recent revision that markedly simplified it. And actually, I think there's now like 7 or 8 subtypes. And it really improved the inter-observer reliability. And they also came up with a scoring system that has also been shown to be easy to use. So this has really, the AO, the recent 2013 classification system has really been gaining traction, especially in my trauma center. So I've been using it more, and we'll kind of talk about it. And it's, you don't need to know it, but it's a nice resource because it's freely available through a Dr. Vaccaro, in 2005, back when the AO was still using the original classification, thought the original one was a little bit too unwieldy. So he came up with this thoracolumbar injury classification system. And there's basically 3 variables associated with the stability of the vertebral body and the prognosis. So easy, rule of threes, which would be mechanism of injury, integrity of the posterior ligamentous complex, and neurological status. Of course, we don't know the neurological status, but there are a couple of things that we can see on the radiographs, the first 2, or the MRI. So he came up with a point, or the group, the trauma study group, of which he was the main author, came up with this point system where the sum of the points would define possible treatment alternatives. And this became pretty popular in the last 10 years. So I would say the TLICS is actually one of the more common ones that you see now being used, as well as the revised AO. So back to Denis. So Denis basically came up with this column of the middle column, and it's kind of controversial because it's not really an anatomical structure, but it's more of a biomechanical structure. And what he basically said is you can divide the thoracic and lumbar vertebra into an anterior column, which should be the anterior half of the vertebral body, and the anterior longitudinal ligament. And then the middle column, which is the posterior half, as well as the posterior longitudinal ligament. And then the posterior column per se, which is basically everything posterior to the middle column, which is all the posterior elements. And what Denis said is that if you had either an isolated anterior column or an isolated posterior column injury, that most of the time these were not unstable. And he actually was one of the first people in his classification to really talk about stability. He thought that stability hinged on the involvement of the middle column. So the middle column, by definition, cannot, or usually cannot, be involved isolated. So it's usually either in combination with the anterior column or the posterior column, and therefore the concept of a two-column fracture is potentially unstable. A 3-column fracture is most likely unstable. When one looks at the schematic from Radcall, basically here's the anterior column with the anterior longitudinal ligament. Here's the middle column which is basically stops at the posterior longitudinal ligament. And then we've got everything in the back, including the facets, the ligamentum flavum, the spinous processes, the supraspinous ligament, and the interspinous ligament. This is from Denis' classification, where basically he looked at 4 different fracture mechanisms: compression fractures, burst fracture, which is a type of compression fracture where you can actually see involvement of the posterior wall and see fracture fragments that are displaced into the canal and can lead to neurological compromise. Seatbelt injuries, we'll talk about these in length. About there's distraction of the posterior column as well as the middle column from a hyperflexion injury. And then a true fracture dislocation, usually in the setting of hyperflexion, but can also happen in hyperextension when there is complete malalignment of the columns and a very high incidence of neurological compromise. So when one looks at this radiograph, basically of a patient who fell from a tree, one can see on the AP view, if you look at the interpedicular distance, that it is widened here at T12. As you remember, the pedicular distance should slightly widen as you go down from level to level. The pedicular distance at T12 should not be wider than the one at L1 as it is here. And one can see the compression on the vertebral body on that AP view. And then the lateral view, of course, shows us the extent of the compression a little bit more in this sort of kind of split type compression fracture. So one of the things to kind of always look for is sort of kind of this alignment and just make sure there's no posterior malalignment. So this was felt to represent kind of a split compression fracture injury. And then this one's a little bit trickier because, again, we see the same thing on the AP, although we see a little bit more collapse of the vertebral body, L1. And when one looks at the lateral view, this looks like your classic wedge compression fracture. So if you think about the Denis concept, Denis basically says that anything posterior to the mid-vertebral body is the middle column. So there definitely is involvement of this quote unquote middle column. And if we look at the alignment here between T12 and L1, there's actually some slight retropulsion of this posterior vertebral wall. So this is a possible burst fracture at L1. With not a lot of comminution, but given the degree of malalignment, that would be a consideration. And according to Denis, two columns or middle column could potentially be unstable. And I think that has led to a lot of confusion where people have thought initially that all burst fractures were unstable. And actually, in consequence, the literature has proven out not so much. We need to kind of have other elements that we need to look for. CT is, of course, extremely helpful when you see this situation because you want to basically see the extent of end plate and vertebral wall involvement, and we'll talk about that. But in this particular example, a compression fracture, which is predominantly involving the anterior half, and you can see there's normal alignment of that middle column, so Denis would think this is a stable construct. But on this one, clearly we could see the comminution of this fracture extending into the superior end plate. There may be potential inferior end plate, although not as well seen on this single slice. You see the anteriorly displaced fragment, so the anterior longitudinal ligament may be compromised. The posterior longitudinal ligament, likewise, we're not sure, may be buckled or may be compromised, but there is definitely a fracture extending into that posterior vertebral wall. And you can see narrowing of this canal. So this, again, is a burst type fracture. The question is this fracture stable or unstable? And when you look at these fractures, not uncommonly, you will actually see a component of it that extends of the fracture sagittally into the posterior elements, which we kind of see right here. So here's the sagittal component of the vertebral body. Clearly, there's involvement of the middle column / posterior wall, but there's also the posterior element. So by all criteria, this should be, quote unquote, an unstable fracture in the knee classification system. However, I would point out that the interspinous distance here is not really splayed a lot. And in this particular instance, these are the kind of fractures where in these days, if you have MRI, it's very good to basically be able to see the integrity of this posterior ligamentous complex. And in fact, this fracture was treated conservatively because there was not a lot of loss of the central canal space by the retropulsed elements. And it was felt that this person could wear a clamshell and not have to, and he healed quite well. Here's another example that I see more and more in my practice. So as you know, the population is aging throughout the world. Seems like one of our referring hospitals, we see a lot of people who are fairly old who get into car accidents. And in this particular instance, this person has osteoporotic, has multiple compression fractures. There was concern as to could there be an acute on chronic injury at this L1 fracture, T12 fracture. You can see that there's displacement posteriorly as well. There is some vacuum phenomena suggesting that there is some chronicity. But because of the fact that of this patient's state, and the clinicians wanted to get an MRI to basically assure that there wasn't an acute injury. Notice the astute person would notice there's also pneumothorax, again, traumatic fractures of the spine, a lot of other injuries that you really have to be careful to evaluate. So on this particular individual, an MRI was performed. There actually was no acute ligamentous injury. In fact, if we look at these T1 images, all of these fractures are old. There's no marrow edema. There's actually they're normal T1 marrow fat. So this patient's severe vertebraplana here, as well as the T11 wedge fracture with kind of a little burst component here with retropulsion is probably chronic. So if one thinks about, the knee would have called this unstable because of the middle column, yet here we have a patient who's obviously been walking in this and doing just fine, and been able to kind of, not have any kind of sequela from it with a stir marrow edema. So again, Denis, very, very popular, very, very user-friendly, very good inter-reader variability. But the middle column is not a true anatomic entity, which is one of the cons of it. Really does not address the posterior ligamentous complex, which we'll talk about. Does not include all fracture patterns. And the term unstable is ambiguous and sometimes really doesn't really apply for treatment guidelines. So enter the AO. So I've never been here, but I'm told this is the AO Research Foundation Center in Switzerland on a typical winter day, I guess. And I don't speak German, but basically this is the German name, and I won't even begin to talk about it. It stands for the Association for the Study of Internal Fixation. It was founded in 1958 in Switzerland by different orthopedic surgeons. And it really has a really large educational outreach on fracture management. I know when I was at UAB in Birmingham, as well as now in Carolinas, many people who come on AO research scholarships and clinical scholarships and so forth. And they actually have multiple divisions. Their most well-known one is on trauma, but they also have a pretty standardized one on spine. They're renowned for their standardization of fracture classification in order to kind of codify research. And they collaborate with multiple different societies, including the Orthopedic Trauma Association here in the United States. So they're very well known. And if you kind of go to their website, you can basically see numerous classification every time a fracture you would ever want to see. It's kind of fun to kind of look at. Many of these are not really used in practice. They're kind of complicated. Some of them are. It depends on your surgeons, but it's a nice way to sort of kind of figure out, the more common fracture patterns and sort of what to look for, which is what I use it for. And when you look at the spine, they actually have several classification systems. One of the I won't talk about the cervical kind of for the odontoid and the atlas, which is unfortunate because I hear about the quiz about that. But I will talk about the thoracolumbar injury classification system. And the reason is it's actually really simple and easy to use. And you can see here that they basically have different types of fractures depending on if it's compression, if it's distraction, and if it's translation. So not a lot of subtypes, makes it easy to remember and easy to look for. On the cervical spine, below C2, one nice thing about it is a lot of these mechanisms are sort of kind of the same as the thoracolumbar, except they actually will basically label facets differently. So if you know the thoracolumbar, you're halfway there to the cervical spine as well. So that's one nice thing about it. So this has become increasingly popular in my center. It's a fairly comprehensive. It can aid surgical decision centers. There's different classification of morphology, as we talked about. We'll talk about A, B, and C. And then there are other components that we really sometimes are not privy to, like the neurological exam or case-specific modifiers for, patient comorbidities. But one of the nice things about it is it's organized so that the higher numbers basically mean a more severe injury. So, for example, a B4 kind of injury or B3 injury is worse than a B1 in the thoracolumbar spine. It's great that it kind of has this checklist approach. So it makes you sort of kind of look more thoroughly at the different elements. I think it can improve communication among the specialists. The coding of injury especially is helpful in research. If there's research institutions that you kind of are associated with. And the imaging morphology by the radiologist really contributes to this multi-specialty approach. It's not very universal, so actually you have to sort of kind of know your local spine surgeons and see if this is something that they're familiar with or even want to use it. And it is difficult to incorporate, just like anything else, if it's new to you. And initially can lead to some readout variability, although the new AO actually is way better for that. Thankfully, there's a lot of material in the internet. The AO has fabulous reference charts and diagrams. I just showed you a couple of them. And then one of the nice things is that RSNA actually has these common data elements that one can import into our templates. And if you look at the common data elements, again, this is from ACR, RAD element, but also RSNA, you can see that they've already got the AO for cervical as well as thoracolumbar and lumbar cervical spine, and kind of gives you sort of different areas, modifiers that you can put in there and use on your templates. It sort of helps with this checklist. I find that very, very useful. Kind of cumbersome to initially do, but then after you get it done with a little help with your IT friends, it really helps. So regarding the anatomical location of injury, the AO basically wants you to choose between, is it mostly one single vertebra or is it a motion segment? And a motion segment is a functional unit with two adjacent vertebrae and intervertebral disc. And there's this concept of the anterior tension band with the anterior longitudinal ligament and the intervertebral disc within it, and then the posterior tension band. And this is also will be called the posterior ligamentous complex, but basically in AO speak, this is posterior tension band. And these are kind of the posterior elements: pedicles, lamina, spinous process, the ligamentum flavum, very important, facet capsules, as well as, very importantly, the supraspinous and interspinous ligaments. Again, from Rad Call, here is the anterior tension band with the anterior longitudinal ligament and that anterior disc, as well as the vertebral bodies. And then the posterior tension band with the supraspinous, interspinous ligaments, ligamentum flavum, and not really shown here, but the facets and the facet capsules. When you look at an MR, we can clearly recognize all these structures: anterior longitudinal ligament here, ligamentum flavum here, facets here, supraspinous ligament, and interspinous ligament. So these are all structures that you have to routinely sort of evaluate on your MRI to kind of determine ligamentous stability or injury. So regarding the morphologies, they basically divide it now in the thoracic spine into a compression injury, a distraction injury, and a translation injury. And a compression injury can occur with the tension band intact, or it can be combined with distraction or translation. In a distraction injury, basically, there's a tension band failure, either of the anterior or posterior tension band that we just talked about, but there is no static translation, i.e. there's still some kind of alignment. So the way I kind of think about this is either the anterior or the posterior hinge, or tension band has failed, but the other one is sort of there. So there is no definite translation. And in a translation or dislocation, there is failure of both the anterior and posterior band. So that's when we see displacement of one vertebral body relative to another. So looking at compression injury without tension band failure, they basically have four subtypes. A0 means that it is non-structural, i.e. spinous process, transverse process, and so forth. An A1 would be a compression injury where one end plate is involved, but no definite involvement of no involvement of the posterior wall. And this would be your very common anterior wedge compression fracture morphology. In an A2, both end plates are involved without the posterior wall. So this is a coronal splitter pincer. And an A3, there's one end plate with a posterior wall, and in an A4, there's both end plates with posterior wall. And these are the burst fractures. They call the one with the one end plate an incomplete, and the one with two end plates complete. And things you need to obviously report. You don't need to remember these different numbers, but you want to basically, when you report, make sure that you look at the end plates and posterior wall and these compression injuries and report them as such. And also look at the percent height loss compared to the posterior cortex or the adjacent uninjured vertebra. So in this example, one can see a transverse process fracture here at L1, or you can see multiple spinous process fractures without any other sign of interspinous distance widening or anything to suggest that there's a posterior ligamentous complex significant injury. So these would be both kind of be A sub 0 type. In an A1, it's a typical wedge compression fracture where we see the anterior loss here. Here's the step off anteriorly, and an A2 is a little bit more uncommon, but you get this very fracture right through the midvertebral body. An A3 is your burst fracture that is predominantly involving one end plate, and there is many slight retropulsion, and in both end plates, you can now see there's a lot more retropulsion here, and this is the fractures that are more typically known as the burst fractures, and you need to define if there is posterior longitudinal complex injury to see if it's unstable. Here's an example we've seen in recently of a burst fracture. Again, there may be this component that extends sagittally into the lamina. One nice thing about the AO, it basically says that, this does not upgrade the injury like in the knee classification. Only if you had a horizontal fracture through the lamina or if there was spinous process, which you then worry about upgrading this to a different type of a fracture like a type B. So in this example, we can see a very gross narrowing of the canal. Obviously, this person had neurological compromise, and one of the things that surgeons sometimes talk about is how much of this is really something that needs to be decompressed. This is highly variable depending on the neurological situation of the patient, but greater than 50% is usually one of the thresholds that some will use. Here's another L2 burst fracture with significant retropulsion. And on the MRI, one can see the same kind of the extent and the degree of narrowing of the central canal. And in this particular burst fracture, there is actually ligamentum flavum injury. So this fracture was actually because of the degree of canal compromise, as well as the posterior ligamentous complex injury was treated surgically. So those are the A's, which are compression. The B's have to do with the posterior band. And they are divided into just purely through the transosseous, so basically distraction. Chance fractures, the most common example. You've got the posterior osteoligamentous disruption, where basically it's going through the ligaments as well as the bone. And this involves a motion segment, meaning that this involves basically two adjacent vertebrae usually, and their discoligamentous attachments. And then the anterior band is something that we typically see with rigid spine, which we'll talk about. And there's usually a rupture of the anterior longitudinal ligament and disc in the adjacent vertebra. So in this example of a fracture, basically there's a little bit of compression. So you would think like, oh, gee, this is a compression fracture. But it's very important to note that there's this component here horizontally that is splaying the pedicles and the lamina. And on the MRI, one can clearly see this. This is just in the bone. And this is a typical example of a chance type fracture. We used to see this very commonly when shoulder straps were not part and it was just lap belt injury. Now, sometimes we'll see this in children who basically haven't been belted properly before the car accident. And here's another example where on the coronals, you can really see quite nicely the horizontal component extending into the posterior elements. So if one were doing the AO game, you would call this a T11, which is the location, and a B1 fracture. So the B2 fracture is, again, similar. A lot of them are type injuries. So you can see that in this example from an educational exhibit, there is actually this component that looks like it, but it's really important to look at the spinous processes, and you can see that there's also, not only does the T12 have this fracture, but the T11, T12 interspinous distance is widened. When we do the MRI, we clearly see why. There's disruption of the ligamentum flavum, interspinous ligaments, and the supraspinous ligament. So this actually kind of is something to look for. When you see a bony component, just make sure that you look at the other components' alignment to imply the status of the posterior ligament complex, because that's very important. So if you were kind of playing along, this would be a T11, T12, B2 fracture, because it's a motion segment. It's not only just the T12 that's involved, but it's also that T11, T12 ligaments. And here's another example, 15-year-old. Basically, one sees this very small little fracture here, but there's a kind of like a focal kyphosis. So you're thinking this is kind of a hyperflexion injury, but clearly there's marked enlargement here or of the distance actually between these facets and the spinous process because there's rotation. When we do the MRI, we can see the clear-cut ligamentum flavum, which should be nice and dark, is completely gone here. And the supraspinous ligament, which should be nice and dark, is also completely gone here. And I've got this other arrows basically showing the extent of the epidural hematoma that some of these fractures will have. So in this example is a T12-L1 B2. Another example of the same kind of process, when you look at this, this looks like a burst fracture, which it kind of is, but there is splaying of these spinous processes. So that basically upgrades it to this kind of B2 kind of injury. And again, you can see the degree of retropulsion of the posterior wall. Another example where you basically see this this horizontal fracture through the transverse process into the lamina. That should make you wary about a distraction injury. And when you look at the facets, these are nicely kind of coupled together, but there's widening here on the left side. You can see that sagittally, the left versus the right. So this was a hyperflexion injury with failure of the posterior band, so B2 kind of fracture. When we did the MRI, interestingly, the CT was a little bit more prominent, but you can actually see there's asymmetry in the fluid in the facets, and there was actually some ligamentum flavum injury as well. A B3 fracture is an anterior tension band disruption. And in this example from the literature, one can see that in the T9 vertebral body, a complete disruption of the anterior vertebra, and the fracture is actually cutting into the disc on this T9. But there is still the posterior longitudinal complex was still intact. So this was a B3 kind of injury, hyperextension injury. We typically see these with the so-called rigid spine, which is classically ankylosing spondylitis with, ossification of the anterior longitudinal ligament and disc. Here you can see the fracture with extensive injury now extending actually through the all the elements here. And this is more kind of and this is a true C. There's a C in the making because there's actually both the anterior posterior tension component has been involved. And in here, you can see the malalignment. So high incidence of neurological compromise in these kind of fractures and obviously unstable. Another fracture from my practice, these are very common. Folks with diffuse idiopathic skeletal hyperostosis or ankylosing spondylitis, and the horizontal component that you can see on these coronals is really characteristic. On the sagittals, widened fracture, we can see the fracture extending into the pedicle, so sort of the same. And then this is the same individual. One can see the extent of the fluid. When you're basically putting these people supine, as you know, they're an extension, so you actually see a lot of fluid accumulate on the MR. And here you can see the ligamentum flavum component as well of this fracture. This is an interesting case because this patient presented with a motor vehicle collision and clearly had a posterior hip fracture dislocation, which was sort of kind of what everybody was looking at. And as you know, in trauma injury, we routinely will look for other injuries. And in this particular individual, we clearly saw this T10 facet fracture. We weren't sure if that was new or old because it looked kind of corticated, but this looked fairly new, and we reported it as such. And even back in retrospect, it is incredibly difficult to see, but there is a tiny radiolucent horizontal component here that was not reported because honestly, it's even hard to see now. But the fact that there was a facet fracture in isolation should have made us think of a possible hyperextension kind of injury. We weren't that smart. And then 10 days later, after he was sort of ambulating from his hip, he noticed his pain was in his back was a lot worse. And they got another repeat CT. And clearly you can see now that fracture, which he has been ambulating. So the whole time this was a B3 hyperextension injury. And I can't tell you, just you have to be extremely careful on these older patients, especially when you see anything that even remotely looks like a hyperextension potential injury, to look for another column being involved because they can be really tough to see. Although I think the coronals are the best to see them. And again, this is that patient now, coronal, and you can see that horizontal fracture and also extending into the facet. So type C is basically both the anterior and posterior tension band are failed. So there's displacement, and that's the key to that. And the disruption, can be through the disc anteriorly, can be through any of the posterior elements or the posterior ligamentous complex. One nice thing about type C is there are no subtypes to remember. So once you see this, it basically is severe enough that for the most part will warrant surgical intervention. Here's an example from the AO of a clear-cut fracture dislocation in the thoracic spine with facet dislocation, as well as really severe neurological canal compromise. Here are some examples from radiographs from our own practice, where basically we can see this abnormal widening and lateral translation on the same patient. These are sponges just from other injuries, and you can see the degree of malalignment, different patient, extensive malalignment, fracture dislocation. A more recent example from our practice at an L1-L2 lateral as well as anterior dislocation. And on the MR, you can see the extent of canal compromise, which unfortunately in this patient was actually not much. This patient actually did not have a lot of neurological injury, thankfully, but this was had to be fixed because it was so unstable. Another example of a type C dislocation, a facet dislocation here in an uncommon location at 5S1, where the 5 facets have jumped the S1 facets, and you can see that on the axials where basically the facets are kind of in front of the other facets where they should be. Note that there's a fracture of the L5 transverse process, as can be seen with the lower ligament avulsion and spinal pelvic dislocation, and you can do these really fun CTs on Terra Recon if you actually have some 3D capability. And here are the facets at 4-5, and then here you can see the 5 facet has actually jumped in front of the S1 facet. Again, another type of dislocation. Here's a T9 burst fracture, but there's also a T8 spinous process fracture. And you can see the malalignment. So once you've got this malalignment, you have to basically think that there is both an anterior and a posterior tension band disruption. One can see the epidural hematoma here associated with the fracture, as well as some epidural hematoma dorsally as well. And when we look at the laterally, we can see the perch facets both here in T8 and actually this displaced facet on the other side. So the AO has this really nice little chart where you can kind of look at, how do you figure out what's what? If there's displacement, that goes to a type C, so that's kind of nice. There's no displacement, then you want to look if there's tension band injury. If it's anterior, that's type B3. If it's posterior, you want to see if it's bone versus bone and ligament, so that's going to stratify it. If there's no tension band injury and it's just the vertebral body, you want to look at the posterior wall. If that's involved, then you want to see which end plates are involved. Both end plates, yes, it's a complete burst. On end plates, incomplete burst. If the posterior wall is not involved, but end plates are involved, then you want to know if both are like a coronal split or just one, which is a wedge compression. And then, of course, if it's just a process or transverse process, spinous process, it's going to be a type 0. So it's actually really easy to kind of look at. So the patient, there is this modifier kind of stuff that they also have, which is kind of nice the way I look at it. Some of this we really, can tell, like rigid spine, M2, but some of this we don't know, like overlying soft tissue, infection risk, so forth, which will kind of modify their surgical risk. But I kind of see this as sort of like a way to hedge the M1 classification, which basically means that we're not sure of the extent of injury, that we think there may be, but we're not sure. So it's kind of a nice way to hedge. And it's a nice way to sort of kind of, be able to get an MRI when we sort of need it to determine if the posterior tension band is involved, which is most of the time when I use it. So in this example, again, from one of the prior educational exhibits that I borrowed from, there's a T7 compression injury, but this spinous process fracture, and that should make us wary about the posterior tension band. So an MRI was performed. One nice thing about the MRI, as you know, is now we're actually seeing the compression injury at T8, which is impossible to see here. But what we really want to focus on is the extent of edema here in the interspinous ligament. However, the supraspinous ligament appears kind of intact. There's not really a gap. The ligament inflammum is definitely intact, and there's a little bit of edema. So this was reported out as an M1 injury, meaning that we thought that there was some posterior ligamentous complex injury, but not a full-fledged, complete injury. And this is neurologically, we really don't kind of have a lot about to do this, but this the clinicians kind of how they stratified between negative exam to transient defect to radiculopathy to equina or spinal cord injury. And it's important to remember that the clinical exam always determines if and when to operate, right? We in imaging help in where to operate, as well as perhaps how to operate anterior posteriorly. And because of initially they didn't have this scoring system, and everybody likes to have these little scoring systems and to add up points, so to tell the insurance company that yes, surgery was definitely indicated, so you should pay for it. We have different points for the injury morphology, neurologic. Notice they kind of get higher as you get higher in worsening injury. And in this spine injury score, greater than 5 points usually has led to surgical intervention. Now, I've spent a lot of time on the AO because that's one that I'm kind of familiar with, and some of my surgeons like to use. But there are others, and TLCIS actually one could say is really more common in many other centers. And this was again introduced in 2005 because the initial AO classification was kind of cumbersome. And this has to do with injury morphology, integrity of the posterior ligamentous complex, and neurological status. Again, a lot of the things that we've been talking about, they ordered a little bit differently. They scored a little bit differently. And in their score, 4 or greater usually predicts surgery. And this is from Radiology Assistant, where basically the morphology, some of the topics that we've been talking about, very similar: compression, burst, translation, distraction. Again, the posterior longitudinal complex, or the so-called posterior tension band. Is it intact? Is it injured? Or is it sort of in between? Not sure. And we need to make that determination usually by MRI. And then neurological status. And again, basically kind of the same phenomena here with compression, burst, translation, and distraction, different points. Just kind of what we're talking about ad nauseum, the ligamentum flavum, the facet joints, and the supraspinous ligament being the most prominent. The interspinous is not as much for the complex integrity. CT, of course, can infer PLC. We've talked about this. This is really important to look for, the wide interspinous distances, avulsion fractures of kind of the spinous processes or facets or a clue, very wide or dislocated facets, another clue, and vertebral body translation, obviously. And if CT is kind of equivocal, then direct visualization by MRI is usually what's indicated, and we can look for either focal disruption or not and give points accordingly. So here's a fracture of T7. We have no posterior elements involvement. Here's a burst fracture, but there's also a fracture of the spinous process, so this sort of kind of upgrades it. Here is clearly a translational injury, so higher level injury, like we've talked about. Here, multiple spinous processes fracture, T11 wedge fracture, but you've also got a T10 spinous fracture. So that tells you that there was a significant distraction injury. And that really upgrades the points on the TLICS on this. And you can see in the MRI, the disruption of the ligamentum flavum is pretty prominent. Their neurological involvement, again, very similar, looking at complete versus incomplete injury. And there are obviously many similarities in the concept. So one of the things I want you to sort of not fear is don't really think they have to know all these classifications. You can always Google them and so forth, but just to kind of continue to look for the different fracture morphology descriptors, compression, distraction, and translation, and describe the components. And that will basically help if anybody wants to classify, they can kind of use that. The AO is primarily descriptive, although now they do have this scoring system, so that's kind of nice. The AO is kind of nice because it's primarily designed for CT as opposed to TLIS, which a lot of times is MRI is needed. So if there is an issue with availability of MRI, then I would think I would favor the AO. So sorry if I kind of went a little further than I should have, but complex topic, but not uncommon thoracolumbar injury. Delays in diagnosis or misdiagnosis are actually not uncommon, and you have to be careful because they can really increase the risk of neurological injury when you ambulate these patients that are potentially unstable. So very important to try to assess it. Various classification systems we talked about, the more common ones, including the still commonly used knee and pitfalls with that, as well as the simplified AO and the TLCIS, which is very commonly used by many surgeons. And the bottom line is to sort of kind of have a checklist for looking at the different morphologies and how to, so you don't miss the fractures, as well as to know what's important to report for the scoring. And we've talked about that. It is important to report these common elements. You can kind of integrate them into your templates. And also it's very important to look at the integrity of that tension bands, either mostly the posterior tension band and the PLC, but also the anterior tension band. And these are the things that I really look for on every CT. I look for, despite even when I see any kind of quote unquote simple compression injury, I want to make sure there's no interspinous distance widening. The facet joints look aligned. There's not a avulsive fracture of the spinous process at the level above, which would basically imply motion segment injury. And then, of course, vertebral subluxation or dislocation. And the assessment of the PLC is sometimes very subtle. These things can be subtle on CT. So you really need to kind of, when you identify what you think is a compression injury, look carefully, make sure there's not a distraction. And if there's any kind of doubt on the CT, the MRI is, of course, very useful for direct visualization. And I think that's all I got. And I really thank you for your time and the opportunity for me to go back and look at my cases and give this talk.
Okay, thank you, Dr. Lopez, for very clear and informative regarding the detail about the imaging of thoracolumbar spinal injury. And you already also described the comprehensive review of the indication of the spinal imaging in the trauma setting, describe each modality and basic anatomy and biomechanism, also discussing the traditional spinal injury classification and the new thoracolumbar injury classification and severity score. Okay, thank you so much for your time. And I have collected in some questions, Dr. Lopez. Actually, in some questions already answers from your last slides. But there is some question maybe I would like deliver to you that, my first question is some centers, not every emergency room is supported by all imaging modalities such as MRI. So as you're described on your case series that you did a complete imaging for the cases. So what is sometimes there is only CT scan and X-ray is mostly available in one center. So what is your recommendation to manage the unstable spinal injury with the neurologic deficit patients with these limitations?
Yeah, I think that like we talked about, the TLCIS is a great classification, but it really emphasizes MRI. And I think in that sense, the AO classification system is more emphasizing CT. I would think that would be more helpful. As you know, these injuries of the posterior ligamentous complex or posterior tension band can be really subtle on CT. So I think one of the things that you have to train yourself, especially if you do a lot of trauma, is when you see one injury, basically look for another injury, right? So we've talked about the fact that there can be non-contiguous injuries and fractures, almost even 20% of the time, which is kind of outrageous. We talked about the fact there are other injuries like major organs, almost 30% of the time, these kind of patients. And then when you go back and you look and you think you have, because the most, what you really don't want to miss is a potential distraction injury of the posterior elements or posterior ligamentous complex. So you really got to look at that alignment carefully on the CT. If the patient sometimes, if you absolutely don't have an MRI, but the patient neurologically is stable, there is a role for, you could do kind of standing views, right? Like we talked about.
Yes.
See if there's any kind of dynamic component to the stability. Unfortunately, as you know, a lot of these patients are really traumatized. You can't really do that. So you can only kind of do the best of your abilities based on mostly CT.
Yeah. Okay, thank you. So mostly CT will help us to see what is a part of involves to this spinal trauma injury. Okay, so thank you so much, Dr. Lopez. And I have another questions. In the patient with fracture at the level of L2, how the injury be classified using AO classification with the LISCS? What will be suggested treatment based on the each systems? This is one questions.
Okay, so they must be referring to a specific example from the talk. So I'd have to go back and kind of look at that.
Sure.
And so I'm not sure which one was the one we were talking about, but I mean, here's one where on the TLICS, we've got this, what looks like a burst fracture at L2 with incredible compromise, which, in the TLCIS, you would actually give that at 2 points. But because there is another component, which is we're now seeing this kind of avulsive injury of the spinous process at L1, then you actually add that. So that's like 3 points. That would be quote unquote 5 points. So, and we know that in their system, anything with 4 is quote unquote potential spinal intervention. So in the AO, actually, this basically, instead of, some people would say this is an A4, but when you see this, that immediately upgrades it to the B, right? So now you've got like a B2. So you could basically say this is an L1-L2 B2, and then under parentheses L2 A4. And that sort of gives the same kind of thing. And if you do the points for the AO, which I don't have up here, again, sort of gives you greater than 5, or I don't know what the number would be at this moment, because I have to go back and calculate it, but it would definitely kind of upgrade it to a surgical thing. So I'm not sure if that's what they were talking about, but some of these things are additive.
So you put every classification in your report, or just one of them to give information to the clinicians?
So at my center, we have a couple of spine surgeons who like the AO. So I do that. I don't do the TLCS, but I don't. That's not like the the lead. The lead should always be in the impression what the fracture morphology is. So you would say this is, there's a burst type compression fracture at L2. And then you would say the degree of retropulsion. You would say if the end plates are involved. So you would give everything that the other clinicians who want to classify it and whatever they want to do, because remember, they have the neurological status of the patient, which is critical, which we don't. So we can only sort of say what we think it is, but they will eventually, be able to say, well, the modifier is this and so forth. And then you would also say there's a distraction injury, with of the spinous process of L1 non-displaced, and possible posterior longitudinal complex or posterior ligamentous complex injury. So I think it's a big mouthful, but if you basically kind of say that on your impression, then people can kind of take that and do whatever classification they feel comfortable with.
Okay. As long as we can describe all the all the structures might be involved to this injury. Okay,
Sure.
and another question is also, which classification is more practical? What is your recommendations?
So I think the TL is easier
Easier,
because it's only
yes, more
got,
simple.
yeah, it actually only has like three components to
Yeah,
it.
yeah.
So I do think that this one's actually more widely used. I think what happened with the AO is initially it was so cumbersome. People said, "Oh, there's no way I'll ever do this." But now that they've simplified it, it's better. But I would say most surgical centers kind of will use this now. The problem with this is there is sort of this you do have to end up doing MR a fair amount of the time on this classification versus on the AO, where you basically have more of a kind of a streamlined approach based on the morphology and CT.
Yeah, yeah. So yeah, based on your table shown the TLIS CS classification, so you have to mention also about the injury type, whether this is compressions, translation, distraction. You have to mention about this. Is that correct?
Correct. Yeah, so you can see here, right? So
Yeah.
everybody's sort of talking the same thing, they're just saying slightly differently, just to, I don't know if to confuse us, but hopefully with this talk we're slightly less confused.
Yes, yes. Okay, thank you so much. And yeah, another things that yeah. So mostly the X-ray is the primary imagings. Yeah, usually everyone's will pass the X-ray first while evaluating the spine trauma. So what is the important clues that must be considered before we follow through the another further imaging modality evaluations?
Right. So I think a lot of this you can, if you're lucky, right, you can see. So obviously displacement dislocation,
Mm-hmm.
you will see this many times in the X-ray. Tension band injuries, I think anterior tension band injuries, if they're severe, maybe, but they're notoriously difficult, as I showed you a case.
Mm-hmm.
Posterior injuries, spinous process injuries. I mean, these are things you can see. Facet injuries are a little harder to see, or you can see, on the typical views. Sometimes you get lucky on the oblique view use and can talk about them. When you have a vertebral body fracture, this all applies to radiographs, right? So, the CT is a little bit better at determining the extent of end plate involvement as well as determining, the posterior wall involvement. But you can see all these things on the radiographs, especially if they're completely disrupted. So, in our trauma center, because of the availability of CT, and because a lot of these patients kind of come in with multiple injuries, they originally get a CT of, say, chest and abdomen, and then we'll go back and do reformats for the
Mm-hmm.
spine. But if somebody, doesn't have that availability, that, just the good old fashioned kind of trauma pack radiographs, looking at the, lateral views of the spine, is also a way to quickly figure out if you've got a significant injury. Now you're going to miss some subtle injuries,
Yeah,
clearly.
yeah,
But
yeah,
it's the
yeah.
same principles as with CT,
Yeah.
right? Looking at alignment, and you're looking at, spinous process injuries, you're looking at disc spaces, uh, and so forth, the extent of height loss, like we looked at a couple of x-rays.
Okay.
So, we've got some examples, sort of, these are classic examples, older examples from one of my colleagues of clear cut stuff that you're not going to miss. But again, when you see this, it's usually the patient's got some serious issues.
Okay. Do you have case?
Any other questions, or am I
Okay,
missing?
sorry. Yeah, maybe sorry. Okay, so this is maybe the last questions that yeah, in degenerative spine case, yeah, sometimes patient always
Oh,
suffer from multiple compressions fractures.
yeah.
Sometimes very tough and difficult in detecting the acute or chronic compression fractures.
Yes.
Based on your experience, how can we differentiate with these two setting of trauma? Yeah, it's acute of chronic.
Right. 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 So I think that is, honestly, you could just give a whole talk on that. I have one case at some point. I don't know if I ran through it, but can't really find it now. Here we go. Here was a case. So it's kind of,
I saw this.
very,
It's very
very
complicated.
common, right? Very
Yes.
common, multiple compression injuries. There's a compression injury of the L4 in play. There's a compression injury of the L3 with actually posterior wall, either osteophyte, most likely it's an osteophyte here. And then if you're not sure about L2, L1's fine, but T12 has this wedge fracture and you've got this disruption here. And you're like, boy, is this widening here, right? So, I mean, this is sort of kind of like, we can't really tell. Now, here's a clue. There's vacuum phenomena. So this basically tells you that there's been some kind of remodeling and you've got some degenerative change associated with it. So if one of the things that we look for is we look for sort of like very ill-defined subchondral sclerosis, like there's an acute component, but sometimes that can be just so hard to see versus, is this just sclerotic from it being there a while? Obviously, this vertebral plana deformity has been there so long, you can actually see vacuum going between it. So this is clear cut that this is old. This most likely is old. This is probably old. This one we thought was old, but the lady was having significant pain. So that prompted us to get the MRI, which showed that it was old. But, again, these are difficult because you've got already a degree of focal kyphosis here, right? So, and if you don't have any priors, right? If you have priors, that'd be great. But a lot of times you don't. So when you don't, then you're stuck with either, if you don't have MRI, you can, try conservative treatment, try to brace them, see if, if they can stand upright. You can even do flexion extensions if the patient is able to, and you're confident that most likely this is not unstable. But most centers in this situation, when there's ambivalence as to, is there an acute injury of the ligaments here, they will do an MRI, which is kind of what we did. And of course, the MRI is very helpful because there's zero marrow edema, so that this lady has been kind of walking around with this for quite some time. But yeah, really difficult to see. But again, I think the principles, like if you saw facet, right, facet fractures, and they were kind of new, I think you'd be more worried about it. That's kind of what I would be kind of focusing on, sort of like, has there been anything here that even remotely looks like there's a new posterior ligament complex injury? And, I think you can actually see a little bit of fat here, which sort of makes me think like, well, there can't be that much edema or anything there. So we thought this was likely chronic, but this ended up getting an MRI. So I just threw it in there because that's actually usually these people just get treated conservatively. So I was like, well,
Okay, thank you so much. Unfortunately, I have to finish the sessions. Thank you so much, Dr. Lopez, for addressing very interesting topic and the cases. And finally, I have to come to the end of the part of the session. And thank you so much once again, Dr. Lopez, and for all attendants, for all your participations. Hope you'll get the beneficial learning regarding the radiologic management of spinal injuries. And I will return the session to Dr. GP, please. Thank you.
Yeah. Thank you so much. Thank you so much, Dr. Setiabadi, for moderating this section. And Dr. Lopez, this was an amazing talk, very well illustrated, very well educated. I love the algorithms, how you kind of split that out, the AWO classification. Excellent. Thank you so much, sir.
Thank you. It's always good to do this because then you realize how much you don't remember of these classification systems until you have to talk about them.
Thank you so much. We'll be moving on to the quiz session right now. And
JP.
before that, we have got Nat here. Nat needs to do some announcement. Please, Nat.
Yes. Thank you. I will take only 1 minute from you guys. So about the quiz session in June, the winner is Dr. Pema from Bhutan. She already got her gift yesterday. And then the winner of the quiz session in July is Dr. Win from Vietnam. And the package is on the way. And I have a plan. No, not I. We have a plan to organize a symposium. How to get ready to be a radiology trainee abroad. This will focus on the USA, and it is possible, if possible, we will include UK, Australia, and New Zealand in here too. Our host will be international medical graduates from radiology training program in those countries. And this symposium is for radiology training. Either you are a radiology resident or fellows and radiologists who want to pursue your careers abroad. And you will have an opportunity to ask a question directly with the IMG in the program. And this is invitation only event. So who is interested in to participate in the event, please email me. My email is on the panelist icon here. You can copy it from there. And at the moment, I am gathering the participant number of the participant at the moment. And the deadline of email is at the end of August. And I will keep you posted by September that this event will be held or not. It depends on the number of participants. And look at my email and please email me. Just say that I'm interested and I'll get you in and we'll let you know by September. So for people who are interested in going for a challenge in the United States, UK, Australia, and New Zealand. Okay, that's it, JP.
Thank you, Nat. Thank you so much. That's a great opportunity there. I would never miss that. All right, coming to the quiz question, you've been having this on the screen right now. I thought I would just challenge this time. I know Dr. Lopez did at thoracolumbar, but we thought we kind of mix this up. So this is basically cervical, but it's very, very kind of basic question. So what type of fracture is this? You see the image there, top two images are on CT, coronal section, and the bottom is a sagittal T2 weighted MR. What type of fracture is this? Is it option A, type 1, option B is type 2, option C is type 3, and option D is type 4 fracture. So your time starts now. You got 2 minutes to answer this question. Please use the QR code, which is seen on the screen. Scan that and answer there. Please do not post your answers on the Q&A or the chat box. I've got those tiny arrows on the fracture there. I think Dr. Lopez, we can have just a cervical fracture talk just on that, probably for like next 1 hour. I guess that's so huge, actually.
Yeah, it's a huge topic. The cervical spine is
Right.
only 7 vertebrae, but it's 50% of all fractures. So yeah.
Right. Oh my goodness. Yeah. True. All right. Last 60 seconds, please. Please scan the QR code, which is seen on your screen to answer the question. You would get the options there. Please answer the questions there. Please do not post the answers in the Q&A. Last 20 seconds. All right, last 10. All right, great. Can we go to the next slide? All right, so the answer is option B. Option B is type 2 odontoid fracture. You can nicely see there in the image, both the CT and then the MR, the break of the odontoid process from the body there. So that's a type 2 fracture. Well, thank you so much, who all got to answer this. All right, so please, we have a evaluation form right now. Can we get the evaluation form slide on the screen, please? So please evaluate this session to get the certificate, and that would be issued only for attendees who complete the evaluation. So please scan the QR code there and evaluate the session, please. And once again, thank you so much, Dr. Lopez and Dr. Sativati, for moderating and for giving this great lecture. We really appreciate your support and help. Thank you. And guys, please do not forget to attend the next session on MRI and ultrasound of the shoulder. That's on 19th August. And please make sure you log on to the same time at 9 a.m. Eastern Time, US Eastern Time. You would be receiving the flyer and the Zoom link soon. Thank you so much.
Thank you, JP.
Thank you. Thank you, Nat. Thank you so much for all the panelists here. Thank you, the IT team, for working behind the screens. Thank you so much. All right. See you next session. Bye.